Welcome to the Low Carb MD Podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor.
Hello and welcome to the Low Carb MD Podcast. Tro, we've done it again. We got another great guest we're excited about.
Yeah.
How you doing, man? And Tro was only an hour late to Gary Fettke's last week or yesterday, so that was awesome, dude. He scheduled it, and who comes in an hour late? Tro. It was hilarious.
We got to take it up with the office manager who makes this happen, who makes all this stuff happen. So we'll give her a pass. Okay, guys, listen, I'm so excited about this one. Somebody I've met several times, just an absolute great guy. I follow him on social media, and he, really interesting person. This is Dr. Stephen Bisho. Okay, he started his training at the University of Virginia for his undergraduate training, and then he went to the UVA for the School of Medicine for med school, and he did his residency training at VCU, where he was the chief resident, and he went on to be the clerkship director and the associate chair of education. And I think that's how we came to really meet each other. He invited me to come talk at VCU, and literally was on a plane ride. It got canceled. This was before COVID, right? And we literally did a Zoom teleconference in the middle of trying to, me literally trying to go travel down to Virginia to give this talk. And we've talked several times before that. We met up in Disney. He's a fellow Disney lover. So, maybe something we can talk about. And some of his, Facebook quotes have really caught my attention. His focus on faith has really inspired me. Recently made a transition from academia to private practice, where he is now helping, small private practice physicians. Well, actually, I should say big private practice physicians get wellness programs set up with health coaches and nutrition. So, and did I mention he's ABOM certified? So I don't think I threw that in there, but also ABOM certified.
Oh, no, I haven't done that yet.
Oh, no, but you know what? He's Sue Wolver certified. So, so you know what? That's actually better. So, Dr. Stephen Bisho, can we call you Stephen?
Yeah, please call me Steve. That's good.
Okay.
Thank you, guys.
Listen, thank you for coming on and stooping down to mine and Brian's level.
No, it's completely the other way. And I know other guests say this, but this is a fanboy morning for me. I'm so excited to talk to y'all. I follow you guys on social media all the time, and I'm like, oh gosh, I can't wait to talk to them. So excited.
People are excited till they actually talk to us, and they're like, that's them. Those are the guys. No, but it's so awesome to have you, man. And Dr. Wolver, we have a ton of, when we interviewed, I was like, wow, she's amazing, man.
Yeah.
I'm glad you got to train under her and get led that way. And you kind of gave us a little background on that, where she's taking people off insulin. You're like, what are you talking about? Right.
Yeah, Sue's amazing. Like I told you a little while ago, and I hope this doesn't offend her. She's my low carb mom. She really woke me up to this whole world and whole community and introduced me to this, and really was the main catalyst for getting me to shift my career back toward patient care, and ultimately making a career change. And I know she might be sad to hear that that she was the catalyst, because I ended up leaving her clinic for a different clinic, but that wasn't any fault of hers. So hopefully she doesn't get sad about that.
So can you walk us through, how do you get started? I mean, you're like a chief resident at a you went to an excellent medical school, excellent residency, you're chief resident, always, you're into academia, you're the education director, improving the quality of education. When did the meat industry come in and corrupt you to support low carb diets? When did the keto companies come and convince you that everything you learned was maybe not completely accurate?
Yeah, it was really interesting that they showed up on the wards one day, and agreed to give me a $5 Panera gift card every time I said somebody should have a ribeye instead of cake.
Yeah.
So it really started from there. and it was a slippery slope.
Guys, we're just kidding. Just so we're absolutely.
Well, I think it's interesting. You were really entrenched in academia. Then you have Tro come speak at Grand Rounds, and all of a sudden you have to find a different job. So probably,
Oh my God.
That was
you were walking through
within
the halls, and people were going, "That's the guy who brought Tro." And actually, I'll tell you, that was an excellent Grand Rounds. I was really impressed by that. That was outstanding.
It was excellent, and it was provocative in a good way. You know, I think, and we were ahead of our time because we did it via Zoom. Who knew this would be the only way to do stuff, just like a year later. So even though your plane didn't make it, you know, it worked out fine, and you know, it was a good message. People stayed till the end of Grand Rounds and to ask questions, and people were still engaged afterward, which is for those of you who go to Grand Rounds on a regular basis, that's not the usual Grand Rounds. So usually people are itching to get out of there at the end. So it was good. It was really good.
So how did you make the switch? Because they didn't teach low carb. I mean, maybe you got taught it. I had a tiny bit of education about it. Was it all Sue Wolver? Like when did the light bulb moment happen for you? Like, wait a second, I can't keep doing what I'm doing.
Yeah, it's really, it's sort of a process. You know, at first, just like most doctors, I had almost no nutritional training. You know, we had a few hours in med school, like everybody says, and it was just sort of like, well, eat low fat and, you know, eat some fruits and vegetables and you'll probably be fine. And then you're looking around like, well, but everybody's overweight and everybody's sick. So I don't really know how this works. And then you get into internal medicine training, and like you guys know, it's really focused on acute care, and, you know, really complicated patients are in the hospital, and it's really hard to pull back and look at the forest rather than the trees of, well, okay, well, they have a DVT and heart failure and this and that, but why is that? Well, it's because they've had terrible obesity for 30 years and they have diabetes, and it's because of their food. And so it really, you know, it really took Sue sort of saying, hey, you know, there's another approach out there. And it also coincided with the fact that I myself needed to lose some weight. You know, I had gained some weight during residency and a little bit after, and really needed to lose some. And so Sue was like, hey, you should try this. And by the way, I'm taking patients off of insulin in clinic and curing their diabetes, or putting it in remission, whatever the current okay phrase to say is about curing diabetes, type 2 diabetes with low carb. And so that's sort of where the ball started getting going with that.
Yeah, Dr. Fetke told me yesterday he's in permanent remission. He said that's the better one. He's in permanent remission from diabetes because of his lifestyle.
I love it.
Yeah, whatever you want to call it, you know, if you're able, like, it's amazing what we're seeing. I mean, that's the thing, and it's exciting. I mean, a guy like you who's in academia, you're training the young docs out there, and all of a sudden the light goes off and you go, wow, we can really help people rather than titrating the drugs and adding more and more drugs. And that's such a different thought, because we're taught to manage everything with the drug. Here's the best drug for high sugars. Here's the best drug for hypertension. And we start realizing we can get to the root of the problem. And that's why it's exciting. So what happened? Like, when did you say, okay, I got to make a change? Was there something in particular, or was it just like the bureaucracy, or what was it where you said, okay, I'm going to make a career change?
You know, and that was a slow kind of couple-year process too. So I started working with Sue in clinic for, you know, a couple days a week, and then that, you know, became a little bit more and more time. And then, you know, we were doing in clinic what I wanted to do when I came to medical school. We were making people well, we were taking them off their drugs, they were feeling better. I mean, it was a joyful place to practice medicine in the low carb clinic space. You know, unlike normal primary care, which can sometimes feel a little like a drudgery. It's like, okay, here's another pill, here's another this. Keep on your low fat diet. We promise it'll work this time. That sort of thing. And so, you know, that joy of practicing really started to kind of take root over time. And I started to see changes in my own, you know, body and health as I followed this, and then, you know, had this opportunity show up from Partner MD to make the switch. And, you know, it made sense at the time, and I swapped, and it's been great. So.
Can I ask you a little question here? So, you know, here you are, okay, focusing on evidence-based medicine. you know, you're chief resident, you're the academic guy, you know, what evidence along the way, certainly like anecdotal evidence, seeing Dr. Wolver being able to make these drastic lifestyle changes in her patients, that has a impressionable impact on you. But at what point does it creep into the academic part of your brain? You know, were there studies that you saw, or, you know, was it like just as you started following the literature, it became too compelling, you know, or was it all anecdotal, or a combination of the two? You know, what's the tipping point where, like, I can't go back to what was going on before, like the 7 small meals, and, you know, what was that tipping point? You know, because look, I mean, on paper, you're like the smartest guy in this room. You know, that's not saying much because it's me and Brian. You know, I'm sure on the exams, even, you're probably smarter than both of us. But so what point, and here you are, you know, focusing on bringing high quality education to medical students and residents, right? And you're the guy who's got to pick the people speaking, who's got to review that. So I'm just wondering, how does the brain change, right? And at what point is it like, are you now on the dark side and you're not coming back, you know?
Yeah,
that's a Disney reference, by the way. So yeah.
Yeah, it's interesting. It's sort of, I think of it like the journey that our patients go through, right? At first there's sort of this skepticism phase, and it's like, okay, well, maybe this is a one-off, you know, okay, great, this person got off this med or they lost some weight, that's great. I mean, people can lose weight doing all kinds of crazy stuff. You know, like there's like a potato diet or mashed potato diet or whatever. People can lose weight doing all kinds of crazy things. So you're like, okay, maybe it's just that. So, but seeing a few patients got me curious. Seeing a few, more than a couple, right? Get off their drugs and lose weight, feel good. It gets you curious. And any good scientist, when they see something like that in the world, they should question the data and see what, maybe there's something here, and get curious about that. So I did. And so I started, actually, you know, I like to keep things organized as much as I can, because there's a lot going on every day. So I just set up some PubMed alerts to come to my email inbox every day for certain keywords, low carb, weight loss, sleep, hunger, these other things. And just started seeing the literature just pour into my inbox every day. It was really interesting. You know, seeing, you know, it just come out this week. I think I tweeted about it yesterday. You know, everyone's worried about, you know, low carb causing gout, uric acid levels in this, and here comes a paper showing, actually, no, quite the opposite of that. So any good scientist, any good doctor who's worth his or her salt and has actually paid attention to their scientific training in med school, they should get curious about what's going on by seeing what's happening to a patient, and then going back in the literature, especially when what's happening to a patient doesn't match what we've been told over time.
Yeah, I think that's critical. Yeah. That's a critical point. You know, Tro and I were noticing stuff, and we made observations. Say, hey, look, here's what Tro even brought it up, right? Here's what I'm saying. Oh, me too, right? So we raised the issue, and people go, you guys are nuts. You should have your license revoked for even talking about this stuff. It's like, what? Our job's to observe and see. Is like what you're saying is a primary. We have to look and say, this isn't working. I got to change my tactic, right? So, you know, we're learning about patients' individuality, like what we're doing, monitoring people. I'm learning it every day. I'm like, it's exciting because I'm learning. Because I say, this guy responded weird to this, and this guy, you know, just last week, coffee. One guy, he's basically type 1 diabetic, barely makes any insulin, and his sugars go crazy when he has coffee, right? And I'm like, is it the caffeine? Is it the coffee? So we raised the issue and go, anyone else seeing this? I have another guy who quit coffee and he loses 9 pounds in a week after like just being, something happened to that guy. Does that mean it's going to happen for everyone? No, but why did that happen? Or was it just a coincidence? I don't know. But you know, this guy with the sugars, like he just doesn't make enough insulin, so he's getting some kind of a stress response or something where his sugars spike like that. So at least we see it, and we have to say, well, let's look at this. Maybe we learn something, right? Or you could say, no,
yeah, maybe it's stimulating his glucose. I mean, who knows?
It's interesting. So it's something, but it's exaggerated in him, but the rest of us may not see that effect because we make enough insulin to overcome that, whatever it is. So that's what I love about what you're doing, is saying, okay, let me observe what's happening. You see people getting better, and you go, okay, I'm going to stay on this track.
Yeah, and so then you really start digging into things, and you know, you can be down a rabbit hole pretty fast on the data, and then, you know, sort of like all the data that's that is out there, and then all the data that's not out there because it's been either purposely buried or denigrated, despite the fact that it's legitimate data. And it's really interesting because, you know, I feel like this whole year my worlds have collided a little bit, because the same things that we were seeing with the low carb research has happened. I don't want to get too political, but has happened with a lot of the COVID data too, right? It's been the same stuff where, you know, we have no idea. And it's the same thing with nutrition, right? We don't really know anything about nutrition, despite all the data that's out there. We don't, you know, the scientific community knows very little definitively about this stuff, despite claims to the contrary. And it's the same thing with COVID. And so you had docs out there in the world who were actually treating these patients saying, hey, this seems to be working, that seems to be working. And then immediately you've got this big institutional response saying, no, don't pay attention to these crazy docs out in the field. They don't know what they're doing. Ignore all of that. You know, just pay attention to us, even though we don't have any data either. So it's really been interesting to watch this whole thing with COVID this year pan out too. Whether it was, you know, certain treatments or masks or whatever it was, there was this very and continues to be this very non-evidence-based approach to the pandemic and to low carb. And so it's really been interesting to watch those parallels.
You know what I think it is? I think it's the fact that, you know, what I've seen in the low carb community, people are willing to listen to dissenting viewpoints, right? That's because if you understand how, you know, one dissenting viewpoint can be, you know, and I want to talk about something Brian had me read a book, you know, A Higher Call, and it's all about, you know, a different viewpoint, a different way to look at the same evidence, right? It's something like you know, in this book, you'd go and say, okay, you know, World War II and the prevailing opinions were, you know, Nazi pilots were terrible humans. And, you know, this whole book is centered around kind of, you know, these moments of faith and love that brought enemies together, you know, and it makes you think, okay, can we look at things in a different way? And then when you're exposed to the data in the low carb realm and the mainstream message, which is low carb is evil, you have to open your mind to say, okay, maybe like groupthink is really wrong here, right? Maybe there's another theme underneath it all. And then when I look at COVID, you know, there is a theme underneath this all that most non-clinicians may not understand. The frauds in the medical journals, the WHO stopping the trials, like there's just, you know, observational data that points in one direction versus another direction. And, you know, leaders saying, you know, do this, not that, you know, public policy being confusing. And it's people want something to hold on to. And I'm not sure that there's anything there to really hold on to. There's just a bunch of questions.
Yeah, I've talked about this with a lot of patients and with my colleagues. And, you know, it's sort of, you know, the wellness guy who had the smallest patient panel coming in, I ended up sort of becoming the COVID expert in the practice too, just because I had the time to review all this as it was coming in. And it's really interesting, you know, because patients, like you said, they're looking for, in the public, they're looking for certainty, and we just can't give it to them, no matter how much we try. Or, you know, if we do give them certainty, it's probably a little bit of false. So I think that in general, people are very uncomfortable with uncertainty in general, and a lot of doctors are too. And I get that. I get it. They want something concrete to hang their hat on, and a lot of times there just isn't anything. And so there's a big temptation to fill that gap with something, whether it's completely accurate or not. And I feel badly for, in a way, you know, Fauci and a lot of the others who have been sort of cornered into giving concrete answers to things when a lot of times there is no answer. And the right answer is just to say, I don't know, and leave it at that.
Yeah, I think that's a hard thing. Pride gets in the way, and we can't just say, we're not sure on this. We haven't seen that. That's why I love certain people out there, you know, like Ben Bickman. He goes, well, I think that, but we don't have data yet to say that, but I think it is true. But it hurts me not to be able to say it's actually 100% true. And I think a lot of people have done that. And I think you raised the point of if I publish a paper that it goes against what the common knowledge is, I may not get that paper published. There's one that I don't know if you guys read about that in Denmark. I think they did a huge study on mask use, and they didn't like the outcome, so no one will publish it.
Yeah, what, 3 journals have rejected it already?
Yeah, 3 journals said we're not publishing that. Well, why? Yeah. Why exactly? You publish the same guys who published fraudulent stuff that had to be retracted, right? So we don't want to do this. Maybe they are afraid something bad's going to happen again, or maybe they don't like the data. I don't know, but that kind of stuff, you have to put it out there. And I think it's the same thing on Twitter, wherever it is. We have to be able to listen to opposing viewpoints. And if we think low carb's the right answer, we should welcome the challenge and be able to, if we can't answer the question, we say, okay, we better figure this out, or maybe they're right.
Yeah, absolutely. I mean, there's things, you know, that don't always make sense. And sometimes you run up against patients where they're not losing weight the way they should. And, you know, things aren't improving in a way. And sometimes it's odd things. You know, I had a patient, and again, you got to bring it back to the patient at the end of the day. The data is important, and the data can guide you and give you some direction, but you've got to look at the patient in front of you. So I had a patient just a couple of weeks ago. He's lost, he's lost 45, 50 pounds, gotten off all of his meds except one for type 2 diabetes, and was doing great. Wanted to lose a few more pounds and started doing intermittent fasting. And so we got him a Lifestyle Libre. He was doing good with that. And I was watching his blood sugars, and he had this paradoxical response to fasting where his blood sugar would shoot up. And it was odd. I didn't expect it. And it seemed like, and we kind of talked a bunch, and we decided that the fasting was stressing his body for whatever reason. And so we stopped doing it, and he went back to eating a small meal in the morning, and his blood sugar normalized again. It was, you know, not something I expected, not something he expected, but you got to look at the patient in front of you and not be so arrogant as to think that every person is going to follow just what you think is going to happen in your brain. So.
Well, you know, I want to talk about this because, you know, a lot of problems happen when things that may make sense, you know, are actually put into clinical and public policy practice, right? So I had a doctor recently who told my patient, you're going to kill your liver with that low carb diet, right? Your liver, you're going to kill the liver because your liver is fatty and you're eating fat. So they think that, you know, the fat that you eat is going to go to your liver, when in fact we demonstrated to this doctor that, hey, this patient's liver fat is decreasing on the blood work and on imaging and on bioimpedance. But it makes sense how you'd think, like, if the liver is fatty and somebody's overweight, that fat would make that happen. I understand why they think that. So there's like a sense of, yeah, it makes some sort of sense, even though the data is against that, right? Now, with masks and with COVID, it like makes sense. Masks would work. We use them in surgery. We use them in the operating room, right? It would make sense that it would prevent transmission. But will the population, how the population uses masks, you know, taking it off to take a sip of coffee, you know, not donning and, you know, not putting it on and off the right way, right? Will this actually translate into any meaningful protection? Will it protect the people who are low income, living in apartment buildings with, you know, 6 people in the same household, right? Or will it just be an incredible waste of time and money for them? We don't really know. So how you take something that makes sense, right? It makes scientific sense, but do we know if it'll come and make a true public health impact? It's not really certain. And that's the problem that I have with, like, I make sense. Masks, I can understand how they make sense. I'm just not sure that the data actually shows that, or how the application of that data, of what we know about masks, would actually have an impact. And the easiest way to say that, this is like a hot button issue, but, you know, if you look at like vaccines make sense, right? They make sense. Okay. Even to some extent, the influenza vaccine makes sense, but, you know, it has a variable efficacy rate every year, 10 to 60%. And very often, you know, we have a flu epidemic every year. So the practical result, even though vaccines make sense, using vaccines makes sense, you know, how we implement influenza vaccination doesn't seem to have a huge, you know, clinical impact, let's say, compared to, you know, measles or smallpox or something like that. So we need to think like, okay, is this translating clinically in public health, into public health policy? And that's where I think the breakdown is, because if you say, hey, I have some questions about the flu vaccine, people are going to jump on you like you're a quack. But it's like, wait. And if you say, hey, I have some questions about a mask, it's like, people are going to jump on you like you're crazy. I think that's a cancel culture. I don't really know, or the intolerance. I don't know. What do you think? So this is a long question. Steve, what do you think about all this? Sorry to put you on the hot spot here.
No, it's fine. I think it's all these things are related, right? I think there's two kind of things going on with all this stuff, whether it's the masks or vaccines in general, whether we're talking about flu or COVID or whatever it is, and low carb. And I think it's people's worldview, right? So whatever their worldview is, the lens through which they view reality is a major determination of how they interpret data and how they act. And then another one is just sort of something we all have, which is just this overall hubris of Western culture and scientific culture that we have the answer, like we know what's going on. And I think usually it's that we've missed some nuance that we didn't appreciate. Masks are one example. So, masks make good sense, right? And the risk benefit ratio in most cases, and especially in large public areas that are not well ventilated, the risk benefit ratio is in favor of wearing them. But the nuance that we're probably missing, and that people make the analogy of the operating room, is that that's a different type of mask, right? That mask is designed for that environment, for that purpose. People are not wearing those out in the community because, well, we were told back in February those were useless and don't buy them, and save those for the healthcare workers. So most people are not wearing surgical masks. They're wearing these neck gaiters and other stuff, and like you said, they're not wearing them right. And my favorite is when people come right up to you and then take the mask down so they can talk to you, and then put it back up. What defeats the whole point.
Well, I think when you start using logic, you say, this doesn't make sense, guys. And when you're the one saying it doesn't make sense, just like all of us are experienced. I raised this issue and I got kind of picked on Twitter, but I said, look, for all my years of medicine, since I was a med student, when I went in to see someone with tuberculosis, I wore a mask. The patient was never wearing a mask, ever. Never, right? Even now in the COVID wards, the patient's not wearing a mask, but everyone else garbs up when you go in. So does having two masks make a difference? There's no study that shows that. We don't have any data on that, but everyone's convinced, like, if you're wearing your mask, don't come yell at me for not wearing a mask. If you take your mask off, then you've just exposed me or I've exposed you. But, we're talking about social distancing and all this. So I think there's a lot of fear and there's a lot of we start to lose our common sense. I mean, the biggest craziness is like this whole thing. You walk in the restaurant, you have to wear a mask, and everyone takes off. People gather and they wear their mask outside. They come inside, they take their mask off. Where's it going to spread the most? Inside, right? Inside. We know that for a fact. We know that for sure. So we start to get into these crazy, instead of saying, let's look at this and really see if it makes a difference. We just say,
backwards public policy, right, Brian?
You're killing people unless you do this, right? So how do we know that? We really need to have data, and that's the problem, is when there's data out and people suppress the data because they don't like the answer, then we're really in a bad situation. The same thing if the low carb people were in charge and they suppressed everything that went against them, they would be just as bad as everyone else. And we kind of see that. Sometimes it's the people in power who say, look, if you're different than me, then and it's the same thing, like what some of the points you've raised. It's like, hey, let's look at the data and let reasonable people decide. Don't suppress one side because you don't like what they're saying. And this is the whole thing with freedom of speech and all that stuff, because most of us have enough common sense to say, yeah, this guy's crazy to say inhale hydrogen peroxide, where or whatever it is, like some crazy thing. People aren't going to say, I'm going to try that because some nutty guy on the internet said that.
Right. Yeah, and it's interesting. I don't know if you guys are fans or familiar of the work by Nassim Taleb. So he's an author, and you guys are familiar with him? Yeah, Black Swan guy. So he actually put out a brief paper early February, before everything hit, when he started seeing all the stuff come out with COVID and et cetera. And I think a lot of his work really applies here. Using the precautionary principle was what he wrote about. Which is when you don't know, the best thing to do is to be conservative and approach things carefully. And this idea of absence of evidence is not the same thing as evidence of absence. Like, just because you don't have data showing something does necessarily work, like the mask doesn't mean that it doesn't. So we should just proceed lightly, right? If it's an easy intervention, it's okay to do, but let's not get dogmatic about it, because we just don't know. We just don't know either way. Proceed lightly. We need to be more humble about how we interpret the world, because we understand way less than we think we do. And I think that that's true across all realms. And, it's no different in our community, the low carb world too. We see these things, we're reporting, we've got more and more data, but, don't be so dogmatic about this or that you're not willing to listen to an opposing viewpoint. Because even if they're not ultimately right, they may have latched onto some nuance that we missed, and maybe we can tweak what we're thinking or how we're approaching something.
Yeah, I wanna talk about that, because I find that I love him, by the way. I love his work. But if you, I think one of the things that's really gotten me wrong is I think the extremes of approach would have worked. Mm-hmm. See, like, here's the first thing I want to start off and say, look at the American public. It's just amazing people, mm-hmm. right? In the first 4 months, they told us, stay at home, mask up, and like everybody did it. Everybody did it. So look at the amazing people in this country. They will do something that if you tell them and you suggest to them and you ask them. So from one element, I want to just point out, like, as a lifestyle, somebody who promotes lifestyle, like, that inspired me. I'm like, these guys, they got it. They know we can motivate people to make change, right? And I'm just thinking, well, what would have been the right message, right? And I think you have two polar opposites that I view as a success. In Korea, they locked down everything, traced everybody. It was like just complete kind of authoritarian measures, and it seemed like it worked. I view that as a success. The other side is like Sweden was like, honestly, just go live your lives, and we're going to pull the tape off quickly. And I view that as a success, right? And they did their best to protect, kind of the elderly. So I view both of them as a success. And I think the middle ground, which Brian was talking about, which is like, you can go to a restaurant, you have to wear it outside, and then you take the mask off inside. All of this, this playing around in the middle, like to appease every different interest group, because we don't have a, solid, vision of what we're going to do to succeed. Right. I think that's the problem. Why is Walmart open? Churches are closed. Right. Why is, gyms closed, bars are open.
Yeah. The bars are open and fast food. And the bigger problem is this. The way I look at it, I have to look at it from our perspective and say, look, what's the best thing I could do for my patient? As a matter of fact, I just had this conversation with my patient. He, in less than 3 months, dropped his A1C from over 8 to under 6. Right. He's lost a ton of weight, visceral fat. He's just killing it. Right. Doing awesome. And I'm like, your chance of dying of COVID has dropped significantly by lifestyle change. And the problem is, we're all going to be exposed at some point. You want to be as healthy as you can. And I'm wondering why the public health people aren't saying, guys, look, it must be political correctness. I have no idea why, or it could be money, because there's no reason they're not going to say, hey guys, watch the fast food, watch the fried foods, watch the stuff that's going to spike your insulin, make you because we know who's dying of this, right? The seniors, and most of it, they're seniors who are surviving who are metabolically healthy. The ones who are dying are metabolically sick, and generally in America, the older we get, the more metabolically sick we get, right? So how come we're not attacking that as a public health, saying, guys, look, this is the approach we have to take? Because if I'm going into a battle, I want to have all my armor on, right? We're telling people, yeah, go into battle without armor, especially make your armor even worse because you sit at home, stress out, be worried. And you raise an important point, Steve, about the amount of Xanax we're writing, the amount of sleeping pills, because right now people are stressed, they're drinking more, they're eating terrible food to remind them of the good old days when they were kids watching Saturday morning cartoons. And it's really, that's something we really, I think that's become abundantly clear in what we're seeing right now.
Yeah, I think you're right. And I think, and that's what we've been, talking about here at our place since, May, June, is that, hey, it's been pretty obvious that the metabolic disease is what's driving the outcomes, in addition to age. And so we can do something about that. But I think the reason that the public health folks haven't, a lot of the public health folks and a lot of the public in general hasn't embraced that approach is because it gets back to this worldview issue, right? They're still in this, they're viewing this in a lens that it's like a tiny outbreak and we're still going to contain it and we're going to keep people from being exposed. And then you've got other people that are probably more on the end of the spectrum where we are thinking, it's in the population, it's endemic, we're not going to get rid of it. Eventually everybody's going to get exposed at some point. So we need to kind of maximize people's resilience to it as much as we can. So that's, I think that's driving these two reactions, is that a lot of people are still in this mode of, we're going to contain it, we're going to find every last case and we're going to nip it. And I don't personally feel like we're going to ever be able to do that at this point.
Well,
at least
and also the next bug comes along and now you're still not protected. So you live in fear the rest of your life. What do you do? I mean, there's definitely consequences to poor metabolic health. And that's very clear. And that's why we're busy, right? Because people are realizing, holy cow, man, I want to make sure I'm taken care of. I've gained 40 pounds during COVID and now I'm sicker than I was before this whole thing. I'm more at risk because I'm not taking care of myself and I can't go to my gym and I can't, I'm drinking all night to calm my nerves. And, we've really caused, we have to look at any treatment we give, we have to look at the risks and benefits and start saying, are risks outweighing the benefits at this point?
Yeah, absolutely. I totally agree. And it's hard, right? Because this is hard. It's not, I can, like I said, we were talking about earlier, I can give you a handout and tell you what to eat in 5 minutes. That's not the hard part. The hard part is the psychology of it, and getting people to a place. You have to meet people where they are, right? It's like having a conversation about faith or anything else. You got to meet people where they are. And some people are really far away and, they just haven't even contemplated the fact that their health is directly related to what they eat. And so they're just not even there. They haven't even, that thought hasn't even crossed their minds. And so their response to everything is, well, give me a pill to take. So that's the people looking, well, if I just take a little more vitamin C or I take a vitamin D supplement, that's gonna fix it. Because I saw this study showing that, normal vitamin D levels are associated with better COVID outcomes. So I'm just going to take a supplement, and that not even to get to all the methodologic problems with association studies, right? It's not taking the vitamin D that's making them healthier. Probably it's the fact that they're metabolically well. So, you got to meet people where they are, and it's tough to find. And it gets back to the individual patient in front of you. We don't have to take everybody from 0 to keto perfection in a month. But getting people to slowly start making changes is a starting point. And it's just hard. It's really hard.
Yeah. And I think, it's like you said, meeting the person where they're at. Like, okay, if you're smoking 2 packs a day, can we get you down to 1? What's going to work for you? And I think, I know people call Tro a zealot. I'm like, obviously you don't know him and you don't listen to what we're talking about, because clearly you're wrong on that. I could tell you that for sure, right? Because we have to adjust. As a matter of fact, I was just glancing because this guy, he has had the least success of anyone. He has the most weight to lose. He's metabolic. This patient I'm taking care of, I'm like frustrated because we're trying everything. Let's add fat in. Let's take fat out. Let's do this. And so I'm like, let's try fasting. Now his sugars have normalized for the first time since I've been in 7 weeks or something crazy, right? So you change tax. You say it's not working. Keto's not working. Low carb. Let's change what we're doing. We've gotten him off a lot of meds, but weight loss isn't happening and sugars aren't getting better, right? But so you change what you're doing. You figure it out. That's why what we do is valuable, because we can look and say, you're not responding like 89 or 90% of my patients. Let's change something and see what happens. And so I think in medicine, we've lost that ability. I think we've lost that ability to, like Tro brings it up a lot, is like, there's a cookie cutter. Your LDL is 130, statin drug. Your sugar's this, insulin. Yeah. Yep. Instead of saying, hey, why is it, like you're saying, why is this happening? Why is your blood pressure elevated? You're stressed out. You can't sleep. And so we're learning so much. As a matter of fact, one thing just recently, this week, Tro, you had a couple of guys there from the East Coast crashing our West Coast party, on Twitter. I mean, on Zoom. Excuse me. And this lady goes, has anyone else noticed they're dreaming again? And like, almost everyone said, yeah, I'm dreaming again. That's right. I wasn't dreaming. And so are they sleeping more soundly? Are they, I don't know why, but people are like, yeah, I'm dreaming at night. Right. It's pretty amazing. You know, these kind of things that we like, I never even thought about dreaming. I'm like, I was dreaming this morning right before you guys woke me up to do this podcast. Right. So you wonder, it's like, wow, that's kind of, you know, we're seeing changes physiologically. So maybe we learned something from that.
Yeah, absolutely. It's and you know, it really is. And it was funny you said dreaming. I had a train of thought, and then I got up because I woke up this morning. I told my wife, I said I had a nightmare last night, and she was like, "What?" I said I had a nightmare. I was forced to eat ice cream all night long, and it was stressing me out. And she said, "That doesn't sound like a nightmare to me." And I'm like, "Well, it was for a low carb doctor. I'm sorry."
Yeah.
So it was funny.
You know,
but that's what I was thinking.
We should talk about that.
Docs.
We should talk about, you know, hunger and sleep. You know, that's a huge topic, right? You know.
Yes.
You know, but go ahead. Sorry, you were talking. I'll keep quiet here. I'll be nice.
No, I'm sorry. I was just going to follow up on Brian was saying, and it gets back to, I think, something we were talking about maybe off camera before we started, that doctors just aren't curious anymore. At least not as curious as they should be. And that's why it's so good to have a primary care doc who is real well versed in these things and is curious, because, you know, you may do something and it should work and you think it should work, but why is it not working? And then turns out, oh, well, I'm doing the low carb thing, but I haven't slept more than 2 hours in the past 3 weeks. And so, yeah, I'm eating low carb, but I'm also eating huge volumes of food because I'm starving all the time or whatever. And, you know, so getting curious about what's actually going on with the patient and stepping back and taking the time to do that is really critical. And I think, you know, not to beat on doctors, but, you know, it's a lack of curiosity, but also they're traumatized and stressed and overworked themselves in most settings, right? So they don't have the mental energy to be curious. And so, and that's, you know, where, you know, the three of us now, and I know, Brian, you made a transition to DPC this year or last year, was it? And
this year, just in July.
Just in July. So, and I made the transition to concierge practice for this reason, so that I have the time and the mental space to really take the best care of people I can. And it's really hard to do that inside of the usual hamster wheel system.
Well, plus, and yourself and your family, right? I think that's the thing, is a lot of docs, I mean, especially female docs, they're in a really bad situation. The suicide rates, I think 130, 140 times the general population, male 40 times higher than the general population, 40% higher. So you look at it and go, geez, why? These are the best and the brightest, and they're killing themselves because they're not helping people. And they're stressed out, they're not sleeping, they're rushing around. And, you know, when we talk about the Mediterranean diet, it's really the Mediterranean lifestyle we're looking at, right? You look at these guys aren't stressed, intense, and hating the world and working 14-hour days, and their lifestyle is totally different than what we do. You know, they walk to the store and get what they need, or they grow it. Totally different than us being stressed out, intense. And I think that's something a lot of docs, and I think that's part of the reason, like, I see the vehement attacks on Twitter, because I go, why would you be, you know, everyone knows my personality. It's like, I'm not going to attack you on Twitter. If we disagree on food, we'll probably agree on something else, right? We might like the same football team or whatever, right? So I think it's when we stop looking at how we're similar and we divide each other, I think that's what I'm seeing in society a lot. Like, people are so divided. Like, oh, you're not really carnivore because you don't eat organs, or you're not really carnivore because you had some cream in your coffee, or whatever it is. So I think we can get very militant and legalistic and tribal, instead of saying, where do we see a common ground? I think that's what, as doctors, we're called to do with our patients. Like, we may have different degrees of, you know, we may see the world differently. It's like, where do we connect? Where's our common ground that we can find and say, okay, you know, you think smoking is not a problem, maybe we cut back and see how you feel, or maybe we cut back on your soda drinking and see what happens. And we see miracles happen because they say, okay, I trust you all, listen. And that's a big thing. I think that's the other thing we've lost, is the trust in the doctor. So if some people say, look, trust me on this, we're going to walk, we'll figure it out. It's going to take some time. We're not going to cure your obesity in a week, right? You're not going to lose 50 pounds this week, but if you lose 2 pounds or 4 pounds, we're going on the right road. And I think that's kind of where we have to build that relationship. And that's the kind of medicine all three of us are in, is that we have time to do that. We have time to really invest, understand you're not sleeping, or you're fighting with your husband, or whatever it is, you know?
Yeah, absolutely. You know, and you know, we're kind of reached a point where if you have a different opinion, not only are you in disagreement with me, you might be evil, right? That's how people act about things, and it's really concerning on every level. And I know Troy, you talked about this before, but you know, I get why people don't trust doctors. we say weird stuff, and we say opposite things, and we change our minds. And you know, again, the not to keep going back to COVID, but the mask thing is the perfect example. You know, all February was don't wear masks, they're useless, and then April comes around, and it's like, oh, well, not only do you have to wear a mask, but it's a crime if you don't. So you know, it's whiplash, and it freaks people out, and I get it.
Yeah, it's basically I don't envy the public policy people. You know, they're when you're in charge of, or when you believe you're in charge of, you know, 350 million people's lives, you know, you may end up going from one extreme to the other in an effort to do good, but I can see how it can cause, I mean, I don't envy them. I don't know what the right answer is. That's the problem. I see two polar opposites, Sweden and Korea, and I'm like, they're both right. You know? You know,
I feel bad. I feel badly for them, very badly. I mean, I've watched them up there. I'm thinking, oh my gosh, this is terrible.
Like, you know, the way I look at it too, Tro, is if you look at Sweden, they're metabolically healthier than we are as a population. So they're going to be able to do better than it's apples and oranges, in my opinion. Of okay, if I have everyone, if for me, if I have an obese diabetic patient, I'm like, social distance, wear your mask, stay away from everyone. If I have an 18-year-old kid who's running marathons, like, you know, they get it and they're probably going to be fine, right? I mean, if you look at the odds and the numbers, and so I think what happens is we get so focused. The problem is this: the data is bad, right? Because if you keep testing that same person for COVID over and over, each time they get positive, that's a case. So you can have the same person be 10 cases of COVID, right? So the case number, the cases are going up. Of course, if you keep testing people that are positive already, it's going to go up. But then when you do that, the mortality rate goes way down, because now you have that same person is not going to, they haven't died obviously because you keep testing them. So I think there's when you look at the entirety of the data and you go, okay, look, I was looking at the CDC data a couple of weeks ago. It may have changed by now, but it was 70,000 college students tested positive for COVID. Out of those 70,000, 3 got hospitalized, 0 deaths.
Right.
So you go, okay, what do you do based on that data? What do you do? Say, keep it all closed down? Or do you say, well, heck, we're not seeing a huge mortality in that age group, right? Does it mean they're going to spread it to grandma and grandpa? Is that what the data shows? So I think part of it is we have to look at the data and kind of understand that some of this stuff is grossly over exaggerated. You know, like, you know, if you're a 17-year-old kid, I as a matter of fact, I was just with a good friend. His son does not go out of the house. He's petrified, and he's sitting in the house all day. It's like, even if he got it, he'd probably be sick for a few days and get better. I mean, the you know, odds are he's a healthy kid, but this fear. And so that's why from the beginning, I said, don't fear COVID, but respect it. You know, social distance, stay away, try to, just like anything. You don't want to get the flu. You don't want to catch whatever, right? But I think that's something we have to look at. Like, we have bad data.
Yeah.
What?
You don't want to, you know, hepatitis, HIV, Ebola, Zika, you know, like it's like all these things, like you take precautions, right, Brian?
Yeah, you be reasonable and don't, like, you know, go on the subway and everyone's packed in. But as an example, reasonable. I just flew recently and I was in the airport and it says social distance. Half the chairs are blocked out. So people are all standing together in a crowd because they can't sit in a chair next to someone. But then you get on the plane, every single seat's full on the plane. Everyone's sitting right next to each other, eating and doing stuff. It's like, well, do you think it automatically disappears when you're sitting down here in the airport? It doesn't, in this huge area that's wide open. Now you're on a small, you know, and now they're saying, well, the filtration systems are really good, but locally it has to get by you to get to the filtration system, or you're going to touch the headrest and touch your eye, whatever it is. But it's like that when you see stuff like that, you say, this just doesn't make sense. And you say something, they go, you're crazy. Well, it doesn't make sense to you. Like when I walk into the restaurant, once I sit down, I don't spread it anymore. But when I'm standing, I do. Like, what does this mean? What's this data? You know? So I think it's those kind of things we really just have to look at it. But some people have their mind made up. You can be in the middle of a trail in Utah somewhere and they're like, oh my gosh, we're within eight miles of each other. So somehow we're going to spread it through the air to each other, like along this huge distance. Right. So, you know, it just kind of comes down to common sense and doing what you can do to keep yourself and your family safe. But being
totally
by fear doesn't help anything.
We flew down to Disney a couple of weeks back with another physician and his wife, and he's an ICU doc here in the community. So he's dealt with a lot of really sick COVID folks since March. And, you know, it was interesting. you know, we got in the airport and people were being pretty good and you know, following the rules and this and that. And then they call us to get on the plane, and then everybody's doing what they always do, right? They're packing the jetway to get on the plane, and then every seat's full, but wear your mask. So there's a lot of contradictory stuff, and it's just odd. And we felt way safer at Disney with all those people than we did on the plane. You know, so it was interesting. It was really interesting. It was really interesting. And this, I'm sorry, go ahead.
No, go ahead.
Oh, no, I was just saying, you know, to zoom it back out, or to bring it a little bit back around to low carb, you know, I see the same thing. They get so hyper focused on one particular item or risk factor or whatever, that they can't see the big picture. And it's the same thing with, you know, and I know you guys have had this before, you know, Troy, you had this, I saw on social media, you had this unfortunate conversation with an endocrinologist this week, and I've had them with cardiologists too in the past, where, okay, well, this patient's lost 40 pounds, their A1C is normal, their triglycerides are normal, the uric acid's normal, and they feel great, and they're all on no meds, but oh my gosh, their LDL went up by 30 points, and so you're killing them. And so it's like, okay, can we zoom out a little bit here and get a little bit of a bigger picture? But that's what's going on with COVID too. People are so zoomed in and focused on one particular thing here or there, that they can't see the big picture here. And we're even seeing it in kids. I mean, I have family members who are, the children who are terrified to go to school because they're convinced that they're going to go into school and get COVID and die. And I'm like, that's not going to happen to you. More than 99%, like, it's not going to happen. But you can't convince them otherwise.
Well, it's the same thing. It's the same mindset as like, I'm not going to ride a bike because I might get hit by a car. I'm not going to,
Right.
fly because I get crashed. Of course, those are always odds. But, we at some point you say, okay, look, the odds and the risk ratio of bad outcome is pretty dang low. Otherwise, none of us would drive our car. If you look at the data on car crashes, you're like, okay, I'm just going to stay at home and stay inside. And I think when we get so fearful, it's really counterproductive. Yeah, for sure.
Yeah, and I think really it's the fact that just society's on edge, right now, and I know, Stephen, when we were talking about this, that we've been, I knew there was a problem, but early March, okay, when I got phone calls that started coming in like never before, asking for anxiolytics and insomnia medications. And then we started asking our patients how they're doing, and they're saying, we're binge eating again. And then we asked them how they're doing with alcohol, and they said, we're binge drinking again. Mm-hmm. And then the calls started coming in about domestic violence and domestic hostility. The kids are home, and the husband and wife are home, and they haven't bonded in years, and now they're thrown into being teachers and caregivers, and sleep quality's decreased. And it was like, it's an election cycle, and the news is driving everybody crazy. I think it's become too much for people to internalize.
It is too much.
So how do you reach your patients? Because I probably described like your entire patient population, right? You're in charge of wellness, right?
Yeah.
How do you reach these people?
Yeah, that's what's going on all year. And, I've really come to feel that at this point, almost everyone in the population is suffering, not to minimize, real, I'm going to say real, not to minimize PTSD that people get from really traumatic events, like, military violence, sexual assaults, that sort of thing. But I think everybody has suffered this moderate to high chronic trauma that just won't stop because it's something new every day in the news. And I think people just cracked at this point. Some people cracked early because they weren't as resilient or they had other troubles. And some people have cracked later and started having trouble with sleeping or whatever. And, so I think at this point, the majority of the population is just chronically traumatized from all these horrible things that keep happening.
Yeah, and I gotta be honest with you, it's leading to a place where people we found, like, it was so desperate at one point. I was like, I just can't field so many phone calls at once. Let's just have group meetings. And then Brian and I, we started doing these group meetings, you know, and we just see the incredible value it is that creating a social network of positivity, it transforms everything. Right? You know, to know that people are suffering the same way, how they're dealing with it, hearing about their successes, what they find hard, you know, we found it to be really good. And then, you know, now, you know, Brian and I were like, you know what, let's just open up our practices to each other. Why would we not broaden this social network, you know, of positivity, hope, and, you know, even not always positive, like what made them struggle, you know, that's also important. Hearing about other people's struggles and how they manage it and how they, you know, what hardships they face, that is important. I don't know of any other way. I told Brian, it's like, we got to make a lifestyle or low carb church, you know, like, because people need it. You know?
And they couldn't go to church, you know, for months. And in some places people still can't. And that's you know, that social connection and the spiritual connection is important. And, you know, when in March, when we sent most of our staff home for social distancing, we deployed our health coaches on Facebook. I mean, and they were doing live sessions, some recorded, but mostly live. It was like, hey, get on and meditate with us for 30 minutes. Hey, we're going to do a yoga session. Hey, here's how to do a workout at home. I mean, just simple stuff, but it was important, and it really kept our patients engaged with us. And then I started getting on every Wednesday and just doing, you know, a COVID reality check, and that's still going on. I do a Facebook Live every Wednesday, and it's our patients just getting on, asking questions, and, you know, trying to just vent a little bit about what's happening. You know, I think just continuing to talk and be engaged with others is critical, and especially be engaged with people who are trying to be grounded, and not trying to hype people up. I think is so important.
Yeah, the news media, look, they when you're anxious and you're glued to them, they win. When you're scared, politicians win. You know, they get to polarize you and make you pick a side, right? I absolutely right. When you're grounded, you know, only you win. You know, not anybody else.
Yeah, the news media is just mostly fear porn. Like, I mean, that's pretty much all it is.
Yeah.
What do you think the answer is? Like, you know, I think the Zoom has been great for people, social interaction, and actually seeing people's faces. You know, I think there's a benefit to that, right? That's seeing someone smile or say, yes, I'm having the same struggles at night, or I'm, you know, wanting to binge more or drink. And so when people see other people are having the same struggles, it really is helpful. And sometimes we could just shut up and listen, and we learn from our patients what they're saying to each other, right? So, you know, I think there's a huge value in the sense of community. And when people are isolated, it's not good. There's studies on this, like social isolation, what a disaster it is for people. You want to make someone crazy, put them in solo isolation, right? Lock them down by themselves for a month and see what happens. I mean, it's really brutal. It is like, people don't talk about this enough. As a matter of fact, one of my patients does software for psychologists and psychiatrists, scheduling. And he goes, these guys are just hammered. Like, they are nonstop online, trying to help people. And he goes, they've never seen anything like this, right? In San Diego, I know the suicide rate is way up, and across the country, across the world, actually. And a lot of them are young people who've just given up hope. They go, look, I'm never gonna be able to get out of my room. It's just life's not worth living. And that's something that we really, really need to focus on.
No, I mean, and just in my county here in Virginia, I've been made aware of at least 2 children who have taken their own lives since the lockdowns. It's terrible. And, you know, a lot of kids and a lot of young people, a lot of people, period, their mental health, they sort of live on the edge, and it doesn't take much to push them over. So, you know, it's really scary, that people are not paying attention to that side of things much in the public policy arena, not as much as they should be.
Yeah, absolutely. You know, absolutely. I think this is the way. You know, we've seen it. It's funny, we've seen the data in the other direction. Actually, we've seen the data in both directions. When you look at Framingham, obesity spreads in social networks and clusters. Everybody knows that study from the New England Journal of Medicine. If you look in that same study, you know, the people who are well also are in clusters. Right. You know, and I think that's part of this is key. And you know what, the brilliant Sue Wolver, when I know she's doing something similar, you know, she has that Facebook group that she manages. Man, I know I'm on the right track then, you know, and when brilliant minds are doing similar things.
Yeah, and I'll tell you a little anecdote here. One of my patients, the family dragged her in because she was having a lot of health problems and gaining weight and miserable during COVID, and she didn't speak English, so we had to work on that. And so, we talked about like life and stress and, other stuff. And the crazy thing is I talked to her and the family said she's not going to listen to you. She's killing it. She's doing awesome, losing weight. Her reflux has gone. Her plantar fasciitis is all this stuff's getting better. And I'm like, how are things? And she had a son that was drinking too much. Guess what? He quit drinking. He's lost 26 pounds. Her husband's like stopped drinking soda every day and he's lost weight. Her neighbor's lost 28 pounds. It's like she's impacting her, like she's learning and she's helping people around her. And that's what you're talking about. It's like, this is not necessarily cultural or genetic. It's like you can really impact people if you get it and say, look, here's what I'm doing. Because for the first 6 weeks, no one listened to her. And then they say, she's lost weight. She looks great. Her energy is great. She's not taking all these pills anymore. Maybe there's hope for me. And I think that whole thing of hope, that things will get better, helps people. And I think this is like, Tro knows, I don't know if you know, Steve, but probably about a month ago, I said something about hope and faith and people went crazy and fought on Twitter for days. I'm like, what is the problem of giving someone hope in a time when everything is dark? I don't see any downside to that, right? People say, well, that's a false hope. You got to have hope because if you think things are going to suck the rest of your life, that's when you kill yourself. That's lack of hope for any improvement. So, but that lady had this hope and she did it. And then she's helping everyone else because they're seeing the fruit in her life of what's happening,
Yeah, no, I agree. I did see that, some of that exchange, and it's interesting. I've experienced some of the same, not quite to that degree, but there's a whole cohort of folks who are just resistant to good news right now, which is interesting. They don't want good news to be shared. They don't want it to be publicized. They don't want other people to latch on to good news because it shakes their worldview, the things they've committed to. But just like you said, getting someone to have a little bit of hope that things can change is often enough, and it's a catalyst. And it's often the mom in the house, right? Okay, mom's going to change the way she eats, and then it sort of spreads to the rest of the family. And it's just a little bit of hope. It doesn't take much to spark it, and it'll have good outcomes. But a lot of people are resistant to that right now.
Yeah, that intrigues me. It intrigues me why some people are so negative and so, you see someone post a picture of them losing 100 pounds. People go, well, look at your loose skin. It's like, how in the heck do you see the same picture I'm seeing and not say that is awesome, right? We can deal with the skin. You look fantastic and you're healthier. And so it's hard because there's always like, it's funny because I see that someone gives a very positive message on YouTube. And there's always one person who thumbs it down. It's like, why are you the only person? Like, do you just have to be contrary? Like, how can you not like see the greatness of what this person's talking about and how they've changed their life and the others? And I was like, oh, you're just doing it for your own ego. It's like, well, they've lost 100 pounds or they've done whatever, they've helped their community somehow. But it's amazing to me that, and, that we stand out if we say positive stuff, and it's crazy. It is, to me, it's like, it's unbelievable. It's like how, I think it's probably because I surround myself with good, positive people. So that's like encouraging. And I've never been disappointed by encouraging someone, even if they don't follow through. At least I can be kind to them. Right?
Yeah.
I mean, it just doesn't make sense. And that's what we do as physicians. That's our job.
Well, it's funny. I mean, like I said, the parallels with COVID and low carb just never end. You see that with COVID, and you see it, in the low carb community, like you just said. And I think probably Sean Baker is one of the biggest examples of that. He looks great. He's in great physical health. He posts these pictures on Instagram or whatever. And then you've always got that one person who's like, oh, well, I'm convinced you're rotting away on the inside. It's like, what are you talking about? Like, it's just bizarre.
Yeah. And I would argue that person who's negative all the time is rotting away on the inside.
Agreed.
Because it's coming out, right? And you see that and you go, gosh, why are you so miserable that you can't be kind to people? Like we've lost that. I mean, that's a crazy thing that it stands out if you are kind and decent. It's weird to me. Like that's how it should be. And it should stand out with people who are, we see people who are very dysfunctional on Twitter consistently, and you look and they have 80,000 followers. Like, is that what you want to follow? Is that, what I mean? They may make a good scientific point, but they're a jerk to everyone. Like at some point you go, okay, is it worth, I don't want to hear vitriol. It just, to me, like you said, good news doesn't sell. That's why we don't have good news outlets, right? Because when you get people stressed and tense and hating the other side, then you get everyone revved up and everyone's using your resources again.
Yeah, I mean, it's just, to make a connection back to faith. I mean, it's just like Christ said in Mark, it's what comes out of a man that defiles him. And it's the same thing. And people bring out of them what's in their heart, whether it's good or bad. It's what's in their heart that comes out of them, and people see it. So, yeah, it's interesting.
Yeah, that's true. And I think that's another area. As a matter of fact, I'm going to steal you from my other podcast and we'll talk about it, because, I'm starting another podcast, Life's Best Medicine, talking about these things: marriage, stress, work, hating your job, being angry at people all the time. This all affects our health. And that's something that in Western medicine, we don't have time. You have an 8-minute appointment. You don't have time to talk about, are you stressed out? Are you not sleeping? Is your wife being mean to you? Or, do you hate your job? But so many people are victims, and they're stuck in a situation that's terrible. And sometimes when you open their eyes to it, they say, oh, that's what we had to do with our jobs before. We had to salary, but there's something that we were missing. So you change what you're doing at some point. You don't have to work their whole life and go, okay, I just worked my life away and I have nothing to show for it. Yeah. So yeah, that's awesome. I'm happy for your patience. And if people want to find you, what do they have to do to track you down?
Probably easiest way is to find me on Twitter. I managed to snag the Gen Med Doc handle. So I've got that. I'm at Gen Med Doc, or you can find me at partnermd.com on our practice website. So.
Awesome. And Tro, do you have any other questions, or are you done interrogating?
No. Look, this was great, man. I love it. I love the discussion. This is it, people. We need level-headed docs out there. That's it, bottom line. And the fact that, you've gone from academia to private practice and managing wellness programs in a big, kind of private practice, it just makes me excited. People don't realize there's no more private practice, right? We are a dying breed here. Mm-hmm. And the fact that we're able to come together, organize a little bit, and offer more and more help to our patients outside of kind of how insurance and academia wants us to practice. I mean, I think this is exciting to me. I want there to be 100 of you. Well, there's only one of you. Okay, but before you leave, I do have one question. This is important. You got it. Okay. The last time I went to Disney, okay, everybody asked me, I'm going on vacation. What do I eat? I fasted 3 days, and I think I went to, where was it? One of the Liberty Square Tavern.
Yeah, down there in Magic Kingdom.
Yeah, in Magic Kingdom. All right, so you're going to Disney. You're going to Magic Kingdom. What do you eat on a low-carb diet? Where do you go to eat? This is what I want to know.
Most of the restaurants have something. You might get like a side or something. But, I mean, honestly, the easiest thing, just go grab one of those giant turkey legs. There's a turkey leg. Just grab it.
Yeah, they got those. I think they're actually ostrich legs, right? I mean,
probably.
There's something else. Yeah, there's a giant turkey leg. Yeah,
they come from Animal Kingdom. They bring them over from Animal Kingdom.
Yeah. So okay, so
probably a lot of vegans mad at us right now. It's okay.
Yeah, that's all right. We'll figure out a way. They can bring their soy.
I've got one I'm bringing on. I love this guy, and he's a vegan, and I don't know how the heck he's doing it. So I'm going to try to figure this guy out. Really great guy. So
I can't wait.
So that's what I mean. It's fun to learn. Like, okay, it's working for you, and your mood's good, and everything's good. Okay, let's figure this out. And
all right.
What are you supplementing? What are you doing? So, yeah, I think it's exciting. Where we are right now in medicine, and I'm just happier. I'm happy to see more doctors like you, and I'm telling you guys, this podcast, I mean, just yesterday, a patient of mine I hadn't seen in a little while. He transitioned over to my care now, and he was out. This guy had identity. He had a disaster in his life, right? He gained like 60 pounds or something like that. His fiance left him. He lost his job. It was like a country song, like terrible stuff. But he goes, I was in Vermont, and I started listening to your podcast, and I walked 25 miles one day. I walked 8 miles another day. And he said, you guys kept me company, and I learned the whole time. And now he's fit, healthy, he looks great. He's like, man, I'm your patient for the rest. But it's one of those things where you start hearing people, like we've had people that were on a tractor somewhere listening to us and doing it. And it's so encouraging, because sometimes you wonder, does anyone listen? Is it really like helping people? And when you hear those stories, like your story, like people in your area are going to find you now, and they're going to have a good doctor who understands this stuff. And that's what's exciting for us, that you know, they shouldn't have to travel all the way to New York to see Tro or California to see me. There's stuff that we can do and have other docs. And as we build this network, I'm getting contacted by doctors all the time saying, oh my gosh, I'm loving medicine again. It's so great that we can have that influence, right?
It's
pretty cool.
freeing, you know, bringing the joy back to what we went to medical school to do. I mean, that's why we went through all that, through all the training, all the studying, all the 80-hour weeks, all that. We went through that so we can help people, not so we can, just give them pills. So.
Amen, man. Amen. So, Tro, you want to close us, man?
No, this has been great. Look, thank you, guys. Did you hear that? If you're at Disney and you want and you're socially distancing, and you want to get a bite to eat fast, and then go get a turkey leg.
That's the way to go.
Yeah, get your burger and throw the bread away, whatever you want to do. I mean, there's so much stuff. If you're really creative, you can figure it out anywhere in the world, pretty much. Yeah. So, and then planning ahead and just knowing that, or you could bring your own food and you save about $50.
Listen, man, just make it easy. Get a turkey leg. I like that.
Do the turkey leg and walk around, do your thing, right?
Disney, Disney goer right now. So you got the advice right here, all right?
That's
I
right.
think it's the best advice you can get.
Yeah. Hey, and everyone, thanks for sticking with us. We went a little long because this is fun for us. We love to shop talk with another doc who gets this stuff, and there's life lessons here and a lot of important stuff. So thanks for sticking with us. Dr. Bishop, awesome. Great pleasure.
Thank you guys so much.
Thanks for all you're doing, man.
I still can't believe y'all had me on. Y'all have the luminaries on, and I'm just a random doc from Richmond. So I thanks for having me on. It's good. It's been great.
Hey, man. This is why we're doing it, docs like you, really, and the people who've lost all hope, and we want to give some hope to that 400-pound, 500-pound person who's just given up, right? Hopefully their friends, family gets this to them, gets it to their docs, and let's have a discussion, right? And we want to have docs who are learning, and Dr. Wolver changed your career and your life by pulling you in and go, look, here's what I'm doing. She could have just kept it to herself and been the only one, right? So I think a lot of us are seeing that, we're seeing the fruit of our labors and what we're doing, and it's awesome stuff. So yeah, we're glad to have you aboard. It's an honor for us to have you on, and we love what you're doing.
Thank you, guys. Y'all have a great day, okay?
You too.
All right.